Good afternoon and welcome to Integrating Disparate Data Sources for a Complete Patient Picture at the Point of Care, a webinar tweet chat combo from healthsystemcio.com sponsored by Holon Solutions. Just a little housekeeping before we get started. My name is Anthony Guerra. I'm the Editor-in-Chief of healthsystemcio.com and I'll be your moderator today. We are hosting a simultaneous tweet chat, which will be hosted by Kate Gamble, our Managing Editor and Director of Social Media. You can participate in a separate browser or on your phone by using the hashtag HSCIOchat, or you can simply view the tweet chat in the Media Viewer panel on the right-hand side of your screen. We'll also be using the Q&A panel today, which you can use to submit your questions at any time. It's in the lower right-hand corner of your screen, and just keep the default set to all panelists. We'll take those later in the program, but again, send them in as they occur to you. And you can download the deck by using the URL on your screen. It's at the bottom of some of our slides, and it's also been sent out in the chat box. Just so you see how we're going to spend our time today, first, we're going to hear from David Coe, VP of Data Management and Analytics with Banner Health. Then we're going to hear from our sponsor, represented by Robert Connely, Chief Strategy Officer with Holon Solutions, and then we'll have our Q&A. So without any further delay, we're going to turn it over to David Coe. David, thanks so much for joining us.
Thank you, Anthony. Hi, everyone. My name is David Coe. As Anthony said, I'm Vice President of Data Management and Analytics, as well as Population Health Technology here at Banner Healthcare. Banner Healthcare is a large system, 28 hospitals located in Arizona, Colorado, and across a number of other states as well, but mainly focused in our corporate center as well, being in Phoenix, Arizona, where I am today. What I'll be speaking about today is the opportunity to look at clinical integration and accountable care organizations and really begin to pull together the data that we need at Banner to be able to best manage our risk-based and value-based populations. As you know, there's a lot driving this out there in our world of healthcare today, and in the ever-changing world of healthcare, we recognize that data and the management and aggregation of data becomes a very important aspect of being successful in accountable care and clinically integrated network models. We have a Medicare health plan, we have a Medicaid health plan, and we have a commercial health plan, and we have joint ventures in all of those. And so in order for us to succeed in CMS and other programs, we really need to do a lot of what we see here on this slide. We need to collect data, aggregate data together, validate that that data is useful, and it allows us to do quality reporting. That's so we can advance our reimbursements, so we can better manage towards effective outcomes and improvement in clinical quality and ultimately the reduction of costs, something we're all quite familiar with. In order to do this, you really have to take the time to invest in your architecture and develop that infrastructure to get you to that place where you can actually be successful in these programs. And this is really but one thing that's really driving this. We also recognize that consumerism is on the rise in healthcare, and it's changing our world day to day and bringing in new entrants into our markets. We see these Google and Amazon and some very large players beginning to explore, again, their interest in healthcare, not only for the population at large, but more so beginning with their own populations of employees. So what we really what we seek to do with clinical integration and accountable care is to have one system that underpins all providers across a continuity-based model, employed, aligned, independent, and so on. In a perfect world, we would have a single system to do all of this, but we don't live in that perfect world, and it's not going to be presented to us anytime soon, I don't think, by any regulation or otherwise that mandates a single EHR system or even a single health information exchange. So with those mandates coming in, how can we succeed in an accountable care organization or a clinically integrated network? In a place like Banner, our employed providers, sort of represented here on the left, are truly clinically integrated already. Those employed providers use our Cerner Millennium tool, our EHR system, and our Healthy Intent tools to manage population health, to record the clinical chart, to do everything that they clinically and administratively need to do. But that's not true of aligned and independent providers. In our market, we have about 2,500 employed and about 5,000 independent providers across our network products. All of those 5,000 are on some 30 different EHR systems across more than 400 locations, and none of those systems talk to each other. So getting access to that clinical information that happens out there in the network beyond the employed providers becomes really, really critical to us. So we've got to pull our providers together as they are aligned and employed, and we need to give them tools that equalize the playing field. Because for as much as we've done to support our employed providers at Banner through clinical integration and adoption of really best-in-class technology, we need to do the same for the affiliates who day-to-day struggle with more portals, more requirements, and more of what they call checkbox medicine, which we believe is contributing substantially to provider burnout. So what we're attempting to do here is to create a clinically integrated network that spans across both the employed providers and the independent providers in a way that allows us to have measurable, provable quality with a consistent clinical protocols so we can control utilization. And that would give us provable network performance, which would in turn allow us to actually be able to know what we're selling, for how much, and to what population, so we can take on that risk. Pulling the providers together and allowing them to govern so we can invest the capital needed in those IT systems and in the humans and in the network that get this work done. Well, that's easier said than done, because what we know today is we have a system that looks something like this. Our employed providers are on a single EHR system. They have their registries, their clinical process models, their risk adjustments, their clinical decision support, all on a single EHR system that's fed by or feeds down to our enterprise data warehouse, which feeds down in turn to our analytics engines, which of course go right back up into the EHR, giving clinical decision support and opportunities to address gaps in care or risk directly in their workflow, a huge benefit to those providers. But as soon as you move over to the aligned space, they could be on any number of other EHRs to which we are not connected and to which we historically have not been able to connect, except through the use of rather brittle HL7 mono or unidirectional interfaces. So in order for an independent or aligned physician to actually get information from us, two things happen. We can only provide them information that we have aggregated and turned into intelligence by way of claims information, not clinical information. And for them to get that information from us so they can take action in the management of our populations, they have to go out to a web portal. Not just one web portal, but many. One for risk adjustment, one for decision support, one for gaps in care, one for eligibility and enrollment, one for referrals. And this is exhausting. In many of our listening sessions, and we do a lot of them with our providers out there in our affiliate space, we hear about the fatigue that this brings forward. We hear the request of, can't you just make it simple? And so we do want to seek to do that, something simple, because it's recognized here by these arrows that go up and down. I can't push data into your EHR, and I can't pull data out of your EHR, so you're going to have to go to these portals. To me, in my opinion, this is an unsustainable model of interaction. So next we get to a place where we can see, look, well, what if we begin to extend our EHR? That's going to be something helpful and useful, and it will be able to help us get to our goal of being able to have EHR and practice applications that are unified, and that will help us with the data. And here we start to see Holon coming in and presenting itself as a solution to be able to help us acquire data from those EHRs. This is an important aspect because historically we've only been able to do this again through rather brittle interfaces, vendor by vendor, practice by practice, and sustaining exceptional cost and frankly creating technical debt along the way that we're going to have to fix later. So acquiring and managing the data using different tools and different points of view becomes a very important part of what we do. Because ultimately what we want to do, and this represents two loops now, a loop going to those who use a single EHR system and an equal loop going out to those who have to or would choose to stay on their own EHR system. So for us, it's ultimately we want to create a platform of tools, services, and care models that use standardized data and metrics led and governed by those providers that drive member and provider engagement who can receive real-time signals at the point of care. And that last piece is the most important piece because that's how we make it simple. What we have done for employed providers using a single EHR system we have to do for affiliate providers who we expect to go into risk or value-based relationships with us. So how do you get those real-time signals to the point of care when that EHR is an EHR that you can't touch today, that would be too expensive to directly interface to, or too complicated to replace, or perhaps you just don't have any governance over the practices that are independent in your network then because they want to be independent, and we want to support their independence, and we want to promote that independence. What are your options? Well, you have some. They're out there, and some of them are more viable than others. Many of you have state HIEs. We have one in Arizona, and it's a very strong HIE. It's been focused on hospitals and delivery systems mainly, and is beginning to work in the space of PCP data, but it hasn't yet. And so if you have PCP data, the HIE is probably a really, really good option for you. But I would still ask the question of how does it get into the workflow, that HIE data? Is it going to be integrated directly into the EHR? And if so, how many integrations are you going to have to do? Next is the interfaces. They are expensive. They tend to be brittle. They break. They're prone to failure. And the cost model really, frankly, in my opinion, of interfaces runs a bit counter to what we're trying to do in value-based care. It's hard for me to get into a world where I'm paying for transactional costs of data when I'm trying to change the fee-for-service model with the providers. I don't want to be in a data fee-for-service model. Portals, that's how we've approached it so far, and the healthcare industry will sell portals because portals sell, and they feel like a solution, but if you go out to those provider offices and you say, what is contributing to your burnout? Where are your staffing costs going? We have providers who almost probably weekly, not monthly, come to me and say, I'm hiring people to do work in portals, to check boxes so I can stay in the network with the hopes that I make enough money from checking those boxes to pay for that person. That seems really onerous. It exhausts them. The portals are contributing to burnout. And again, we have to ask the question, what does a portal do when it is outside of the workflow? And I would offer that it creates retrospective look-back activities that are administrative in nature and not clinical in nature. And if we seek to have providers, and not just their staff, but providers themselves thinking about value-based care and shifting the behaviors around value-based care to knowing what to do in a moment of time when someone is in the office and in the exam room with them, but they're still on their own EHR system, we have to think differently about this. Now, of course, you could think, well, let's give everybody a single EHR, and certainly there are ACOs and CINs that have tried to do that, and I would say that the end solution of all of this, maybe not in my lifetime, is a single EHR or a single HIE, but until that shows up, we've got to do something more unique than that. You can count on APIs, and the developers in many of our EHR systems are beginning to come forward with more robust APIs. But again, is that really going to solve the problem over the long run of being able to interoperate your data in the way that you want it to aggregate in one place? Of course, there's FHIR, but then there's emerging technologies, which brings us to the folks who are here sponsoring this with us, and that's Holon. So our solution is to go with Holon, which essentially allows us to do three really interesting things. Holon calls this a tap on the shoulder. And I have come to adopt that phrase when I go out and install this technology in different provider offices with our teams. And our teams go out and they talk about this tap on the shoulder. Think about it like this. The Holon tool simply is a widget. It's a service that runs on the desktop of any computer that you install it on. So if you install it in 5 computers and 5 exam rooms in the offices of one of your affiliate practices, now you're able to do 2 things. Number one is you can set it up so it can sense the context of a chart being opened. So when David Coe goes into his PCP, and my PCP is in the exam room with me, and I'm sitting at the end of that funny little couch on that wrinkly piece of paper, that exam table, I can now know that when he opens my chart, 5 to 6, maybe 8 seconds later, a little alert will pop up in the workflow and say, yep, this is a member. It'll validate that I'm enrolled because it shows that I'm enrolled. It shows what product I'm enrolled in. And then it will list any number of pieces of information that I want to communicate. So we began our process by putting gaps in care there. So we have our Cerner Healthy Intent engine, and we partnered Cerner and Holon and ourselves to get together to figure out how to lift those gaps in care from our registries up out of our Cerner tools, broadcast them over to Holon, who holds on to them and waits for David Coe to go in an exam room. Once I show up in the exam room, that alert pops up, and that provider now knows I'm eligible, I'm a part of the network, what part of the network I'm a member of, and then tells me those gaps in care. The idea here is that over time, the providers will start to take activity that is clinical and not administrative, and take a clinical set of activity in the EHR in that moment when I'm in the exam room with them, addressing gaps in care or risk things or any number of other pieces of information, be it ADT or otherwise, that I might want a provider to know about my population. Once they take that information into their minds, and it's not prescriptive information, it is literally a tap on the shoulder. Hey, don't forget, this is a member. You're at risk for this member. Here's some things we know, and since you're at risk, you might want to do something about it. They can click and learn more by opening up the slider tray represented on step number 3, or they can actually just proceed as planned, making some adjustments perhaps in what care they were going to do, but document it in the EHR. And so long as they document it in the EHR, the Holon tool actually can reach into the EHR specific to discrete fields and pull that data back. That sensing technology that looks for the context of who's in the room, because what provider's in the room and what chart got opened, can also reach in and pull discrete fields and bring it back. And so we can now actually bring data from disparate EHR systems without an interface back into our Healthy Intent tool and our other analytics and business intelligence tools to generate more information, because now we can close faster those gaps which emerge for those patients, those members. Because previously we were waiting for claims data, now we can close it with clinical data. And if this becomes a comprehensive model and is adopted in the practices as we plan over time, they won't need to go to portals for this stuff anymore, because it will be taken care of and measured using the Holon tool. This is a pretty big promise of this technology, is the actual capability of not interrupting a provider, telling them something they need to know when it's the time to know it, not hitting them with a fire hose of information, but instead just tapping them on the shoulder and saying, hey, don't forget there's things you can do here. And if you code it and document it the right way, the eventuality is we won't need these portals anymore, which is a pretty exciting place to be. We installed this in our first set of practices, and we went back to the practice. Our provider relations group, which is not our IT group, went out to the practices and asked them, how do you feel about the Holon tool? And the practice manager said, if you take it away from me, I will break your arm, which was a great statement. And I've told this story because it really means something to me personally, but it means a lot to a lot of folks around here too. That I don't know if I've ever done a clinical technology deployment and had that kind of response within the first 10 days of adoption. Very typically, you do technology deployments, and it's questions and challenges and difficulty, and only with the Holon tool have I ever heard people say, don't take it away from me, within the first 10 days of adoption. We went to another practice recently who's been adopting it, and they had tons of interesting questions and gave us a lot of learning and really challenged the way we think about alerts and challenged the way we think about interaction with the offices. And then they said, okay, well, you've got a lot of questions, so we're going to go ahead and we're just going to turn it off and we're going to tune it up, and then we'll be back like in 3 or 4 days with the tool, and we'll come back and we'll retrain on it. And they said, oh, no, don't turn it off. We like it. We just want it better. And it suddenly felt like collaboration instead of this thing that sometimes we can get with offices, which is we have a new tool for you, we have a portal for you, we expect you to go somewhere, we expect you to do something. There's like saying, don't take this away. It's an incredible piece of technology, which ultimately draws us out to something like this, and this is our innovation model. In our Banner Aetna joint venture, which is the only commercial product for Aetna in Arizona anymore, and a true joint venture for us where we share in risk across these populations in the commercial space, we're working with IBM Watson and a number of other really interesting data intelligence groups, as you can see on the far left side, and how important it is for Holon to serve us in this model in the independent provider space, to be able to capture that data, bring it in, process it through, and then send it back out. Because ultimately we want to be able to do something deeply, deeply innovative with this information, which is create a personal health record, to create opportunity alerts that can be broadcast out to any number of applications in our space: price transparency, single billing, provider search, e-clipboard, virtual care. The Holon tool fits within all of these, because the ability for us to send those signals to the point of care, to the provider in that moment when they're dealing with our member, becomes a vital part of any application architecture that we're going to need in the future. So my last 2 slides is to ask some questions as a call to action. What is your future of clinical integration? How will you get EHR data from those independent practices? If you have signals to send, when do you send the signals? Do you wait for someone to show up and think, oh, maybe I should go look for signals? This is a question of push versus pull. And if you're going to push, then how do you get those push signals into a workflow, competing with dozens of other payers and health system signals? Don't forget that we are but maybe 5% of some of our practices' panels. We might be more than that, we might be less than that, but the point is we're not 100% of anybody's panel. And they have every single other payer and provider and delivery system asking them to do all these same types of things. So how will you get data faster? Is it important to have data faster so you can create more and more actionable information, so your alerts are more timely? For some measures under CMS and the accountable care, HEDIS, STARS, and so forth, those measures are satisfied with claims, and that's certainly good enough for those measures. But how are you driving improvement? It's beyond just measures. And how will you support your network as they get into MIPS and MACRA and other value-based contracting? Because the speed of information is going to be critical to that. Because what we know is you have to manage the data, and this will help you to manage the network. And when you have a highly tuned and well-curated network, the network will help you manage the population. And that's the end of my slides, and now I'm going to hand it back to Anthony.
All right, very good, David. That was an excellent presentation, and I certainly learned a lot. Now we are going to hear from Robert Connely. So Robert, let me give you the control, and we look forward to hearing a little bit about Holon.
Thank you, Anthony, and thanks, David, for giving us that wonderful glimpse into your world. I'd also like to thank everyone on the line today for taking the time to be here. For those who are on the tweet chat, I encourage you to use the hashtag #LiberateTheData or @HolonSolutions to bring attention to our cause during the presentation. So with that, who is Holon and why is Holon here? Well, Holon is what we like to call an information surfacing company in healthcare. We deliver critical patient-specific insights into the provider workflow, as David mentioned, at the point of care through a unique bidirectional delivery technology. To us, we believe that technology done well should be invisible to the end user, so we've gone through tremendous lengths to keep providers happy and in their workflow. So our goal really is to reimagine interoperability, if you will, because in some cases, interoperability could be as simple as a tap on the provider's shoulders in our minds, as David mentioned. So as a team, throughout our careers, we've been fortunate enough to have had the opportunity and to experience many of the faces of healthcare. We've witnessed the delivery side of care all the way to the health plan side of care. We've worked with some of our nation's largest labs and for a few of the most widely deployed EHRs and HIEs in the country. So with this quote-unquote scar tissue, as we endearingly refer to it, we've made liberating the data and surfacing interactive insights that lead to optimal patient care our core mission as Holon. So who do we serve? Well, our clients, generally speaking, are risk-bearing provider organizations and health plans and healthcare technology companies or vendors. But as you'll see, as we kind of go into the presentation, you'll see more and more about the platform itself. Our sphere of influence around who we serve is broadening over the course of time, and it will probably change going forward into the future. So David did a great job explaining what we do, but I want to hone it down onto one specific thing that's the fact that we have a point-of-care platform which surfaces contextual, interactive insights to the right people at the right time. And I know most people, when they hear the word platform, they immediately think of marketplaces and apps and app stores and things. And while that may be true, what we really want to do is have a conduit for solving one problem, and then problems 2 through N are easily solvable with a minor tweak or a modular adjustment to the platform itself that could then be propagated to the full community. So why are we different? Well, we've seen that there are other types of user interfaces that are similar to this, but one thing that we've done is we've built, we are now in the final stages of awardance for 7 different patents for this sensory-based technology. And the one core pillar in our philosophy is that we're going to be vendor agnostic always. We want to bring the right focus to the interoperability challenge and really hone down on what we do best and let everyone else do the analytics and other kinds of things that we aren't necessarily the best at to work with us in their endeavor. And so if you imagine if you're a David Coe at a Banner and you've made significant investments already in other kinds of vendor systems, we want to take advantage of those investments and let Holon focus 100% on the reimagined interoperability case. In the year that we've gone to market, we've already brought on more than 6,000 clinical users in a little over 900 locations, and we have many more to come already. So how does it work? Well, Holon has basically put together this revolutionary sensor-based technology that David alluded to, and effectively, as David mentioned, we can automatically detect when, let's say, a patient's chart is opened in an EHR. So if you imagine, the patent being we take third-party analytic content and surface it into the third-party workflow of an EHR, specific to the patient needs at the point of care, that is pretty much everything that we do. The key here, as David pointed out, is that there's now no more switching between various applications or portals or spending countless hours after hours trying to glean information about your patients once they've already left this encounter. Instead, Holon now provides a gateway for all of the other applications to be imparted directly into the workflow. So I like to think of this in an easy metaphor like the human body. If you think of all of the investments you've made in analytics and data warehousing and other kinds of things, think of that as the human brain. Holon is effectively the nervous system, transacting output from the brain down to the EHR peripherals in the community. This also works in a closed-loop scenario or philosophy or theory. So think of the fact that if you had ACO analytics or health plan analytics or really any third-party application output that you wanted to get in front of the providers when they're with patients at the point of care, we could surface that in an unobtrusive overlay, very much like a ribbon, that could provide things such as gaps in care or coding opportunities or risk scores or frequent flyer to the ED kind of alerts. All of this information could be presented to the users in context of the patient's chart that they're in. But moreover, as David pointed out, we can acquire content if you would like to be brought back into our system and propagated forward upstream to the sponsors of the community and the network, so that you no longer have to go to the portals to fill out RAF forms or other kinds of documentation that's already been filled out in the EHR, really minimizing the time and effort and cost that it would traditionally take to bring this awareness factor throughout the community to run a more seamless population health program. With that, we put together a suite of products in our first year to market called CollaboraNet. The products are Connect, Insights, and Referrals. With Connect, that's effectively the automatic sharing of clinical data between providers, health plans, and analytics engines. That thing that acquires content from the third-party EHRs, curates it out, and propagates it upstream to our sponsors is really what Connect is as a package. Insights is that tap on the shoulder, that real-time interactive patient information at the point of care that's really purposed to allowing providers a broader scope when understanding what's going on with their patients, which might not necessarily be already documented in the EHR. So for example, is their hemoglobin A1C a gap in their care at the moment? Well, it depends, because if you're with a contract with Aetna, it might be if it's over 7%, but if it's a contract with United, if you have a 9% HbA1c, maybe that's a gap. We normalize and reconcile those gaps by contract, and we can present that easily and spoon-feed it to the users in the EMR. And then, of course, a referrals module or application. We facilitate electronic collaboration across health communities. We're actually participating now in one of the largest closed-loop statewide innovation models in a state, and we think that whenever folks can start steering patients appropriately, care is better for it. So if we are able to present that, oh, this individual is an ACO member. Oh, by the way, they also have gaps in their care. And thirdly, what if we could present the fact that based on geographic proximity to the patient, cost, or quality, we suggest that this individual should be referred to this location. And we also facilitate that transaction happening. So with that, I would like to encourage that everyone download the slides. I have a few extras in here that we can keep for future, and I will pass it back to you, Anthony.
Very good, very good. Thank you, Robert. All right, we have time for some questions, so go ahead and send them in the Q&A box, and I will take a look at them. All right, gentlemen, first question. Robert, let's go with you on this first. What are your thoughts as to the implementation of middleware or ESB solutions and microservices for integrating disparate systems, as well as transforming data on the fly? Why does the healthcare industry often seem to be reluctant to embrace these strategies for integration and are typically not part of the conversation when they have been used successfully in other industries such as finance?
That's a great question.
It's a mouthful.
Yeah. So first of all, finance is another animal altogether. I think, my knee-jerk reaction when I hear the ATM analogy or finance is that the good thing in finance is, the number 20 is always the number 20 regardless which ATM you come up to, and therefore there's no discrepancy in that. In healthcare, it's a wildly different beast in that you can have certain metrics for care or certain things related to a patient that aren't necessarily the same depending on who you talk to. However, it's interpreted by a system or an analytics engine, et cetera. But to the prior part of the question around the implementation of middleware or enterprise service bus solutions, microservices, et cetera, I think that is a very viable case for transforming data or for sharing in data across communities. I think middleware is a very good fit when it comes to actually transacting information. I know that, obviously transforming data, I think is what was said, is a little risky depending on when you transform it, upstream or downstream, because of the way in which one must interpret data in order to transform it appropriately. But I feel like a middleware solution, if provisioned appropriately and well, can be in fact the answer to sharing information more easily across systems, because you can create a canonical format in the middle that folks can adhere to, and then of course transact data in a singular, mutually agreed upon way on the endpoints, which kind of mitigates a lot of the risk when it comes to scaling, because now you're not having to reinvent the wheel each and every time you bring on a new participant or constituent within the network.
David, any thoughts?
I would agree with what Rob said, and MDM and middleware in healthcare really I would only add, really needs to be mindful of creating copies and replications of data, and that ultimately that should be avoided. We need to really have MDM be truly MDM, and so the use of middleware, I think, is going to emerge very strongly in healthcare in the next probably even 18 months.
Very good. All right, sticking with MDM, let's stick with you, David. Can you offer lessons and suggestions on MDM, master data management used for syncing data from different sources, as part of a disparate data source integration?
Yeah, I can. I would say that the aspects of MDM for me, I think of MDM as a result of good data governance. And that if we have good data governance, we'll be able to define the architecture of the solution, what the ESBs need to be, and so forth. But ultimately being able to put a master data set in the middle, using tools like we're talking about with Holon today and how does this work with that, is now you actually could start to bring that information into a master data set for members and patients and be able to ultimately find what's happening in that moment. So there's a lot about MDM out there that we can talk about. We're really just starting our journey in it, and for me, it's really a result of good data governance, and without a good governance model, you're not going to have MDM.
Robert, did you want to touch on that?
Yeah. So you know, we've kind of, speaking back to the scar tissue, we've always in healthcare kind of referred to MDM, master data management, as, you know, 3 general ways for solving that. One is either you acquire or merge the organizations managing governance that way, and then forcing everyone upon a singular EHR record, which might be great, and I think David's presentation did a good job explaining where the limitations are there. The next 2 are really, how do you manage the data in a community setting or in an enterprise across, you know, you have the patient identity and then derivatives of the patient, their data, either by doing upstream management of data, normalizing data somewhere at the beginning and putting it into sort of like an HIE or something akin to a data warehouse. And then I know a couple of other vendors are trying to focus more on late binding of data, so downstream efforts to say, okay, if everything's flat in its format and storage faculty until a moment and it's recalled, then we can bind the data together in a late binding way and be able to manage the data at the endpoint that way. I would like to propose that in the future, it actually might have a 4th opportunity as well. When we're looking at blockchains and other kind of distributed remote technologies, you can think of everyone having a shared contract in a ledger. Think of the data that you have on an individual patient being shared. Well, what if it's not really shared, but really everyone has their own copy of the data? And every time the data has been updated, that update is shared to denote that your copy needs to also be updated. And I think that that's going to create a net new opportunity going forward into the future that we've seen variants of in our past that we can expound upon.
Very good, Robert. Question, does your solution integrate with Apple Health?
So right now, we have not to date done any integrations with Apple Health, though I would love to start exploring an integration opportunity there. We primarily have a number of different vendors that we can work with offline with folks to kind of talk about where we have engaged and where we haven't. And the way we kind of attack the community and start building out our infrastructure in a new community is our customers will bring the vendors of whom they're working with to us, and we will start working with them. If they've already been somebody that we've integrated with, we create a template for that integration, and that way we can kind of use that and leverage it for implementations 2 through N so that the expediency factor is there. But no, not yet to Apple Health.
Okay, very good. David, question is actually for both of you, but let's start with you. Can you both send and receive CCDA procedure documents currently?
We are receiving CCDA information and more using the Holon tool, which is very nice that we're actually able to pull that down and bring that in. We have other methodologies across Banner for doing the same, but not necessarily in the affiliate space like we're building here. So yeah, we are able to do that. That's definitely a big key factor, and that was the initial reason I engaged with Holon, was to be able to pull that type of information and more into our environment. The part where we really started to look towards pleasing providers was learning along the way as well. So yes, we can. Rob?
Yes, you pretty much answered it for me.
Okay. All right, very good. Next question for David. How are you aggregating clinical and claims data, including adjudicated claims, and mapping to a single ontology, seeing as all EMRs can vary in their data fields?
So the first part of the answer is we have a number of engagements with vendor partner organizations, the main one here being Cerner and their Healthy Intent platform, which allows us to bring the data into a population health point of view with known measurements, architecture, ontology, everything else around it. And so that really works out quite well for us to be able to do that. We are able to take in the data from all of these disparate EHR systems using the Holon tool, and the work of the Holon tool, because nothing's magic, even though it may feel like magic, the heavy lift is that mapping of those discrete fields within those EHRs, so the Holon tool is pulling the right information back across. Once we do that, we're actually able to go back and work with Cerner and pull that together and drop it into our population health data mart, which allows us to actively close gaps and work with that data in a much more facile way.
What about medical imaging, David? How does that work here?
So we have our medical imaging files go into our EDW, and we work through our Teradata EDW to manage into that kind of data.
Okay,
so
very good.
Yep.
Okay. Next question, David. Do you use NLP technology, and how are you doing predictive analytics on your population?
Okay, yeah, so we do use NLP. We've got it all over the place. We've got NLP working with
I like
IBM. Yeah, we've got NLP working in our IBM Watson environment that we're building for the joint venture to create a personalized health record for our members that will be portable and ultimately will be distributed across a blockchain if everything goes well. But it will be in an application architecture for use by the members. In that case, we're using a lot of NLP and some very advanced analytics with our Base Health partners. Base Health is a younger group and something of a startup, and they're doing amazing work on actually risk stratification going towards just not predictive analytics but prescriptive analytics, where they're actually able to identify cohorts with shared comorbidities and calculate using NLP the likely financial cost and implication and impactability of an individual based on their record. And so we've got a lot of that kind of activity going on. I mean, for us, ultimately, we're going to use the Watson platform and other platforms, but mainly in the joint venture. The Watson platform for us holds the promise of being able to look at member information as consumer information and find opportunities for engagement, and we're building towards that future right now as well.
Very good. David, how are you managing your provider network, being the entire CIN, total cost of care for a specific chronic condition, and provider performance and utilization?
We have all sorts of different risk, and if I understand the question, our provider network, it's a self-driven provider network. The board is providers. They're able and have the governance, and our CIN model as it's developing is really putting them in the driver's seat as independent and affiliated physicians to be able to understand their own risk. These tools play a big part into that. But ultimately for us, we want to be able to go into places where we assume full risk and we have known networks that can manage that risk. So our future will be the ability for us to understand when we are looking at a population, be it a consumer population, employee group, or sponsored group, and to understand what elements of our network would be in best service, be it geographically or by diagnosis or by population profile. Because I think what we believe is that in the future, the bet is not on the population necessarily, it's on the provider's capabilities of being able to manage that population. And so in a clinically integrated network, having a tiered provider network or the ability to curate a specific subset of that network for a population and then sell individual products essentially in that space where we might think, oh, well, they have a lot of lower back injuries in this population because it's a warehouse group. What might we do to, drive forward a high-value network offering benefit for providers or for those populations that need specific types of health benefit, and really be able to tier that out. That's really a big part of why we need this data from all these affiliated EHRs, so we can really begin to understand and contract the best way possible with those providers who want to remain independent but are very willing to take on risk and move to the future with us.
All right, great. Couple of questions for you, Robert. Does Holon offer its own analytics platform engine that customers have to use with your connectivity solution?
We don't. So that's actually a really great question. Because we're completely agnostic to the analytics tools and we want to focus 100% on re-envisioning and reimagining the interoperability challenge, we want you to take advantage of the systems and tools for analysis that you've already procured, and we want to partner with those vendors. So I know that, some folks may have built analytic systems and they want to kind of boil the ocean on everything. We want them to partner with us so that we can really help take the data and the analytics and the intelligence that they've imparted and bring it into the workflow on their behalf, so they don't have to deal with the minutia of all of the different variants of EHR deployments and the like.
Very good. Should folks consider Holon a population health management vendor?
So that's a good question too. It's hard to say. I would say that we certainly help others in their population health management initiatives, especially when it comes to managing risk across a community. But I think that as we've devised the platform, and if you close your eyes and imagine all the things you could do if you were only aware that, say, your member of the population health system or community is present at an encounter currently, what would you do with that opportunity, has led us into new paths where we're actually engaged further beyond the simple influence of population health, but turning it on its head. What if we flipped population health upside down and turned it into personalized medicine? What if, to David's point about base health, if we knew causality, which was different than correlation in care, and we said specific to this individual, your population health analytics have put forward this information as an aggregate, but we can distill out that one individual's information, and now we've created personalized medicine with that. And now we deal with the clinical research organizations and the lab vendors and all of the others who are well beyond the sphere of population health that kind of also get brought into the fold. So I would say we're not a population health management vendor. We're far more than that.
And then last question for you, what is the average duration of an implementation?
So that also depends. It's in varying stages depending on who the person that's evaluating is. So if you're David at the very top of the enterprise level, looking at the entire community split up by different variants and facets, there's a few months to deploy the entire product out into that community depending on the specific use case. But if you're the practice administrator and you're trying to turn it on for the first time for your physicians, and you're the physician sitting in on the first introductory meeting, the install of the product itself is somewhat of a non-event. It's a next, click install. If you're an enterprise, we have MSIs where you can propagate that out to the entire enterprise through a centralized IT faculty. But then when we deal with EMR vendor systems, if it's an EMR system we've worked with before, we have templates for standing that up. There could be about a week or so time frame for turning it on. If it's a net new vendor, and there are new vendors coming out of the woodwork every day that we've not seen, then we like to ask for at least 3 weeks of due diligence and discovery time so that we can evaluate to make sure that if you're requesting data out of the system, that A, the system's being documented appropriately and that the data is accessible, and B, if you're looking to surface actionable or interactive insights into the workflow, that getting the context for the patient's chart and focus is something that we can do. And so it really depends, but it's immensely shorter. It's a fraction of the cost and the time and the effort over the traditional methodologies for bringing forward these types of solutions.
Excellent. Well, that's about all we had time for today. When we close out your WebEx window today, you'll be taken to a post-event survey. If you could answer that, we would appreciate it. Regarding continuing education, those of you who hold the CHIME CHCIO certification get 1 CEU for attending our webinars. So let CHIME know you were here, and if you asked us to do so, we certainly will. If you need a certificate of attendance for another CEU program, you can use the final slide in this deck. You'll receive an email when our archive recording has been posted to our YouTube channel. And if you'd like us to produce a webinar on the topic of your choice, you can reach out to Nancy Wilcox. And you can go to our website to view our upcoming schedule of events. So with that, I want to thank our panel, David Coe and Robert Connely. I want to thank Holon Solutions for sponsoring this event and making this great education possible, and I want to thank you, our attendees, for continuing to come to our events. So with that, everybody have a wonderful day. Thank you.